Symposium. Coach has come a long way since 2000 and has gone through a variety of situations, which has given us a courage to walk a bit more and take risk, which has also given us new insights to continue and promote mental health. Mental health is definitely a challenge, very often we come across apprehensions and doubts by caregivers as to when is the appropriate time for my ward to get married, when my ward start working, is mental illness inheritable, when will my son become responsible? Such questions keep arising. With this symposium, we would like to throw light on these pertinent issues through a series of short talks, a debate, and discussion by an array of learned speakers. Key topic which will be covered in the symposium are need for COVID vaccination. Is schizophrenia inheritable? Addiction, suicide, marriage, employment, and therapeutic approach of effective communication and music. Hoping at the end of the symposium, everyone is more enriched and knowledgeable while being more understanding and empathetic towards those with psychological disabilities. We have envisioned a community whose mental health is as much a priority as physical health. Thank you.
All right, thank you so much, Neeta. Okay, and for sharing with us this entire program. It most definitely seems very interesting and very informative. So before we begin, I would like to request each participant to mute their microphones. So currently what we have done is that we have made all our speakers co-hosts. Okay, so we would request you to to take over, okay, and also to share your own screens and share your own presentations. We will give you the permission for the same. But the rest of the participants, I would kindly request you to switch off your microphones and switch off your videos if possible. All right. Kindly send us in your questions through the chat box. All right. And we will definitely address them all only after all the three topics are being presented. Okay. Any questions or any queries that you have or problems, kindly just put in a text in our chat box and we will be able to deal with it eventually. Kindly requesting Neeta to just share her screen. Yeah, thank you so much. Okay, so usually the most common question and a very important question that is asked by most families is whether they can inherit schizophrenia with a family history of the same. So to address this, I would like to welcome Dr. Vantimar Sriraj from NIMHANS. Okay, he is an assistant professor in the Clinical Research Center for Neuromodulation in Psychiatry, Department of Psychiatry, NIMHANS. The scientific publications that he has done are in the chapters of 5 books, and peer-reviewed publications that he has done are 60. Yeah, I've lost.
And I thank Dr. Peter as well for organizing such a good symposium. I was going through the list. There are a lot of interesting speakers and interesting topics that are lined up. And this one of the important question has been important topic, I should say, it has been given to me. Because of the wide kind of an audience that we have, I have tried to keep it simple, but it is not yet simple enough. There's a little bit more technical, I suppose, but I will be, please feel free to ask questions and to give the answers in a more simple way later on. So coming to the topic, so is schizophrenia inheritable? If I have to say a direct answer, no, we don't actually know. Uh, Depending on the studies that were done in early 50s and 60s, the heritability. So when I talk about heritability, technically we try to say that if a disease can be transmitted across the generation, that is from parents to their children through the means of genes. Okay, so then we call it as heritable. So 80% of whatever the causation, different causative factors could be there for schizophrenia, they felt that it could be explained by the genes, and only 20% will be from the environment factors. But that might not be the true case. We'll try to understand it more now. But yeah, this is where things started in the 1950s, 60s, and 70s. So that was the period where we started feeling this. But before moving ahead, for those who are not yet initiated entirely into schizophrenia, we try to have a very brief introduction on schizophrenia. So schizophrenia, most of us who are working in this area or who are suffering and have seen other people who are having the illness, we would know that it is not a single illness or it's not a single disease. Okay, it's a combination of different symptoms, different signs, and common features. When we see the commonality across different things, we try to put them together and call them as schizophrenia. So if I'm having a schizophrenia, I might be having positive symptoms, that I will start getting few unusual experiences. I would have few unusual beliefs with which I'm not able to coming out those beliefs. If I have negative symptoms, then I might lose interest in my activities. I might not be able to feel the pleasure the way that I used to feel it earlier. I might even start losing the ability to attend to the things, plan out things, execute the things, these which we call as cognitive deficits. And mine, all the symptoms will be present in all the individuals, but many of the symptoms will be present in many individuals, and they present in different combinations of as well as in severity as well. And the same thing will get reflected when it's transmitted also. It need not transmit entirely. Okay, if I have to make it a bit more simple, schizophrenia is heterogeneous. It's present in such a wide variety. It's like a garden. It's not a flowering plant. Okay, it's not like a rose plant, but it is a garden of different things. And what we are trying to do is try to distinguish them, put them across, and make them into categorize them into different flowers, which has not we are not yet succeeded in that. So for that reason, we are able to see multiple things, multiple genes, multiple pathways, which might not be true for each individual. So we need to understand that transmissibility or whatever that we say is not, it cannot be generalized across each individual. We need to consider each one of us separately and then try to understand if we have this question of inheritance and the risk that we will be posing to the people who will be inheriting us. So coming to this, so I was talking about multiple symptoms, domains, or multiple patterns of presentation, and each pattern, when we look at it, so it can be as narrow as only 40%. It's not that all the presentations which I might be having, I will be transmitting it to my son or the daughter. Okay, and the risk is even much lesser. So look at what exactly is the risk. If I am having illness, my son is going to have the illness at a 10%, around 13%. That is, that I have 100 children, then 13 children. It's like 1 in 10 children might get illness. It's again might get illness. Okay, and this is just an increase from 1%. If I don't have any family member having an illness, then my risk will be 1%. Okay, so from 1 to 10%. So that's the only minute increase that we will be seeing. But when we talk about genes, okay, so we have one of the important things that we try to see is how much of the twins, because twins, as we know, there are two types of twins, monozygotic or also called as identical twins, who have similar kind of a genetic makeup. Okay, they look similar, they have similar genes, that's why, and they will also have same environment in the early part of life, that is from conception onwards. till they get birth. So if the identical twins have 100%, then we can say the illness is 100% transmissible and 100% of it is caused by the genes, but that is not the case here. So identical twins only have 48%, that is only 1 in 2 of the twins will develop. It's like if I have got schizophrenia, my twin brother would be having only 50% risk. He might develop or he might not develop, that is at 50% level. And if it is not an identical twin, it's a fraternal twin, this reduces further as low as 1 in 5 risk. Okay, and this heritability, if I have compared with other disorders, other known disorders which might not have, which we can think more clearly as having more environmental or more behavioral kind of a variant, it's like alcoholism or drug abuse. So even their heritability comes to as high as around 70%, and it's not very less than 80% what we have been estimated with schizophrenia. So so these numbers of heritability might be as good, though the risk that we are seeing families could be influencing some of our decisions. And another important aspect or the additional aspect that we need to know is about the risk is not just related to the schizophrenia. Like if I have a schizophrenia, then there is a higher risk of my children who might be developing other disorders, maybe substance use disorders, maybe bipolar disorders. So these are the two important disorders which we see more often, and most of the psychiatric disorders actually happen more often than in general population. But I would also would tell here that it's not just the disorders which happen at a higher level, it's also other things. It's like creativity, intellectual ability. These are also found to be co-inheriting with schizophrenia. Many of the times we see the individuals who are first degree, who are close related to the individuals with schizophrenia, they might have higher creativity. Take for the example, one of the brilliant fellow, that is Albert Einstein, even his son had schizophrenia. And so the examples go on the high number of lists. So there are both positive sides and negative sides of inheriting the genes of schizophrenia versus developing the illness itself. Okay. So, so coming to some of the basics of genes. So when we try to understand genes, all of us would be understanding or would have gone through our primary school studies where we would have heard about Mendel's and Mendelian rules. So we would be very scared that 1 in 5, I would be having a risk of 50%, 25%. So those are very high risks that we could see in Mendelian disorders. Those are single gene disorders. So if it is happening from one gene, but that's not the case with schizophrenia. Here there will be multiple genes which will be affected. Okay, and the resultant is the effect of it's a multiple protective genes. There's a lot of genes, and it's a fight between the protective genes and deleterious genes, and sometimes it might go here and there, and it's based on how much of the deleterious gene have finally could lead to the resultant field. And the consequence, that is the onset of the illness, might not just be related to the genes. The genes are manipulable. They can be manipulated, and this manipulation need not happen all the time voluntarily. Most of the times, and maximum times, it happens involuntarily, and it happens through the environment. Environment can influence how our gene work, how our gene behaves, and even it can change the presence or absence of the genes as well. Okay, so when we come to schizophrenia, that's where we call it as multifactorial causation. It is not a genetic disorder, it's not just an environmental disorder, but it is the combination of both of these that are going to play. And if you look at what are the kind of a genes, so as I was telling, multiple genes have been found to be associated, and not all genes are present in all individuals with schizophrenia, and none of them will have all the genes that are associated with schizophrenia. But some of the genes that have been found out are mostly, as we can expect, are related to the, that is genes which have functions on the neurons, the cells in the brain, or the circuits of the brain, or the hormones or the factors which will be improving or reducing the activity of the nerves and their growth and the development. But recently, one of the profound results that we have been consistently seeing over in the last decade or so is the impact of the genes which are related to the general immune system. So we have been hearing a lot about immune system these days, thanks to COVID. And we also are hearing about a lot of things about the cytokine. And we know that COVID, when it happens, it is not just because of the virus, but it is how our body reacts, the body's immune function, when it goes and it overreacts to the virus are coming, and that's where the problems can happen, and that's where the cytokine storm happens, and a lot of complications would arise. And the same thing would be happening here in schizophrenia. The dysregulation of these genes, which might be happening more during the prenatal or the natal, that is during the child is still it's in the fetal stage or during the early childhood. So that's where the stress can act on this immune systems, and these immune systems can flourish and they can get dysregulated and would be contributing to the onset of schizophrenia. So if you see this Manhattan plot, the only one, the biggest building among all the things that we are seeing is not the brain structures or the brain function related genes, but it is the immune function related gene. So this immune system is something which is coming up as a most likely candidate to have a major role to play. So getting back to the environment. So as I was talking about the heritability, so the 80% heritability, the first slide where I started, when we start looking at exactly the genes that we are able to identify till now and try to see how much of these genes can explain, it's only the 20% of the genes which the molecular studies that we are able to understand that how the illness is being developing. But in the maximum, that is 60%, it is this gene and the environment that the interact is happening is something which is provoking and leading on to the illness. So yes, there are a lot of environmental factors. Most of them are near the birth, before birth, during birth, after birth, the childhood. So prenatal, like the season of the birth, primarily related to a lot of viral infections that could be happening, or it could be related to the obstetric complications that one might have developed. It's about the delayed cry soon after birth that could be happening. So all increases the risk. Okay, again, I am not saying it will cause, but they increases the risk for development of illness. And similarly, there could be abuse which will be happening in the childhood, urbanicity and migration. So all this increases the risk for development of schizophrenia. One of the important factors which can definitely be regulated is the cannabis use. Okay, the cannabis use primarily during the adolescent has been found again and again to have a major impact in those individuals who have susceptibility, who have higher risk, as cannabis use is something which is going to trigger and can actually destroy the course of the illness. Right. So when we are looking at gene environmental interactions, one of the common example that I could share with you is one of our findings about, again, IX, the interleukin, or it's one of the cytokine, the immune function gene. Okay, there is one IL-6, that's interleukin 6, which is also, so this is something, there is a regulatory gene, which the gene which regulates the functioning of this IL-6.
This thing?
And IL-6 can, in healthy individuals, it actually reduces the volume of certain brain, primarily the brain region called hippocampus. Hippocampus, it is the brain region which is the memory center, which primarily works for improving the memory. Whatever the memory storage happens, it happens through this hippocampus. And the deleterious gene mutations that will be happening in healthy individuals are found to reduce the hippocampal volume. But those individuals who have schizophrenia, it actually works in a different way. Here, those who have deleterious gene, which is generally considered as deleterious, can actually increase. Okay, can actually increase the hippocampal volume, and it can actually be protective in those individuals. So there is nothing called good and bad. There is nothing called white and gray when it comes to genes and environment here. So there is nothing called right or wrong. If someone tells, did I do any wrong when I developed this illness, I would have an absolute answer that no, there is no mistake of yours or your parents or anyone that you developed this illness. It's quite more complicated, and it's an incidental happening. But when we are at this stage, we have to look at future and try to see how we can progress further. So finally concluding, I would say genes do play a role. environmental also plays an equally important role. And interaction is something which is more important, and it is a bit more difficult. And a lot still needs to be known about how this interaction happens. And hopefully, we are quite hopeful that we will be able to understand these interactions better, so that in future we will be able to come out with what are all the different factors. If we can prevent them, or if we can manipulate, we will be able to prevent one person from developing an illness, even though he's having the risk factors. So with this, I would like to conclude. And as they say, the brain and the genes are not so simple, they are complex. And if they would have been so simple, our brain would have been so simple that we could have been able to understand, then we would have been so simple that we would not been able to understand that. So with that, I would like to end my presentation and request the organizers to take over. And if there are any questions, I can pick it up based on how the organizers advise. Thank you.
Thank you so much, Doctor, for such a very informative session. And just a reminder to everybody, we will take in your questions only after the first three talks are presented. Post that, we will take all your questions. Okay, over to the next speaker. According to the World Health Organization, each year about 1 million people die to suicide across the world, and it is the largest contributor to the decreased life expectancy in individuals with schizophrenia. To understand this at a much deeper level, I would like to invite our very own managing director at Cooj Mental Health Foundation, Dr. Peter Castellino. He is the founder and director of Cooj Mental Health Foundation, a consultant psychiatrist having his own private practice. He has initiated programs in psychosocial rehabilitation of people with psychological disabilities, suicide prevention, and geriatric and dementia care. He was a past president of the Psychiatric Society of Goa, the member of the Goa State Mental Health Authority. He is a member of the International Association for Suicide Prevention and is a fellow of the Indian Psychiatric Society and has received the Bagadia Award from them. Calling Dr. Peter to take over. Thank you.
Yeah, thank you. Okay. Can you all hear me? Am I audible?
Yes, sir.
Yes, doctor.
Yes, I am. Okay. Before I start my presentation, I would just like to tell you that my network is very unstable, and so in case I go off, please bear with me for a little while. I'll come back. So I just want to inform you about that. But suddenly today, the net is playing havoc. Hey, thank you for the kind introduction, and I would like to really thank everyone for participating in this very significant symposium that we're having on a topic which has a lot of gray areas, and we hope that by the end of these 2 days, we'll be able to throw some light on the various facets of schizophrenia. Now, the topic that I will be talking to about is suicide and schizophrenia. Now, it is a very important topic because we know by and large we lose a lot of people to suicide itself. But now we would like to focus a little bit more on the subpopulation of people with schizophrenia and see how that figures out in the large picture of suicide. Okay, I'll go here. Yeah. Yeah. So if you look at the statistics, we see globally around 8 lakh people die to suicide every year. Now, this 8 lakh that we see is only the tip of the iceberg. It's only those cases that are reported. We do really know that numbers of suicide still go unreported all over the world and even in our country. And among the 8 lakh people that die to suicide globally, India accounts to around 139,000. So if we see, there's a huge percentage of people that are dying to suicide, which come from our country, which represent in the larger global statistics. So if you look at the rate of suicide in our country, it's 10.4 per lakh population. And unfortunately in Goa, it is 16.8. It is much higher than the national average. I mean, we would hope that in a state which has better literacy rate, we will see we would hope to see a lower suicide rate. But unfortunately in India, we see southern states of India, which are higher, which have higher literacy rates and better economies, actually contribute to a larger number of suicides in our country. And we see for every one person that dies to suicide, there are almost 20 more who have attempted and survived. So that number which we saw of 8 lakh has now multiplied 20 times to see the number of people who have actually attempted suicide. And for every person that dies to suicide, 20 are have attempted suicide and 100 more are contemplating suicide. So the 8 lakh has gone on to 80 lakh people who are contemplating suicide around the world. And if you look at the ratio for male and female, if in high income countries, the ratio is 3:1, 3 male is to 1 female that is dying by suicide. And in low and middle income countries, the ratio is a little bit, the gap is a little bit lesser, 1.5:1. Yeah, I just put in this slide because it helps us to see where India stands in the global picture of suicides. And India, as you see, is brick red, which shows that a large number of suicides coming from India, from the Soviet Union, and very few other countries, but India actually is responsible for a large number of suicides. We would say that our population is a lot more, but you see China, which has a higher suicide rate, which has a higher population, actually has a lower suicide rate. One second, I've put it wrong. One second, I'll have to stop sharing. Excuse me, I've put the wrong slide. One second. Yes. Okay, now I get you the. Yeah. Now, if you look at the World Suicide Report that came out in 2014, mental illness was seen as a significant risk factor for suicide. Okay, have I? Is my presentation come on?
Yes, doctor.
Current slide, yeah, it's come on, okay. Yeah, so mental illness is a significant risk factor for suicide. But very interesting, if you look at the data coming in from Western countries like the United States, UK, and if you look at those South Asian countries like India, we find that in the Western countries, 90% of the suicides are probably due to a mental illness. Whereas in South Asian countries like India, that figure actually drops. And they say that a larger number of suicides are due to interpersonal relationship factors. So that is a huge difference between the contribution of mental illness as a factor for suicides in Western countries versus South Asian countries. And if you look at the risk factors, and if you look at the blue and the pink, you will see, if you go to the pink, we'll see previous suicide attempts, mental disorders, harmful use of alcohol, and the first one in relationships, that's a sense of isolation and lack of social support, relationship conflicts, and discord or loss. Those are very significant risk factors for anyone who is attempted suicide, who is thinking of suicide. But you see, a lot of these factors are also seen with people who have schizophrenia, and therefore there is an overlap. If you look at the blue factors, the blue are more universal factors, barriers to accessing healthcare. And we see mental health care in our country is not very good. I mean, it's getting there, but it's still far from what is really required and adequate. And therefore, that itself becomes a huge risk factor for suicide in people with not only schizophrenia, but any mental illness. Yes. And again, if you see in the societal level, stigma associated with help-seeking behavior. So again, we know the stigma attached to mental illnesses is very high, and therefore which then becomes a contributor to the risk of suicide. And any program that is required to help in prevention of suicide needs to factor in all these areas like stigma reduction, appropriate media reporting rather than inappropriate media reporting, prevention, access to means, improving the healthcare services, and at the individual level, and helping people with mental health issues to actually get the right kind of care. So what I will do is I will go through a few slides which is specific to schizophrenia and suicide for us to get a better understanding of what could be the contributory factors. So if you look at schizophrenia, suicide actually is the major cause of morbidity and mortality. And if you look at the rate of suicide among people with schizophrenia, this is alarmingly high. 1 out of 4 persons with schizophrenia die to suicide somewhere around the world. And most common cause of premature death in schizophrenia is suicide. So if you look at these 3 issues, these 3 points that I've placed before you, we realize the importance of helping people with schizophrenia deal with their suicidal ideation. What are the various factors of suicide in people with schizophrenia? Number 1 is age. And we see suicidal behavior in schizophrenia is usually more common in patients below the age of 45. And here we see it's not only really the age which is important, but it is also the time when the illness started. And this schizophrenia generally starts off early on in age. And patients with schizophrenia tend to have a significantly higher risk for suicide during the first 10 years of their disorder. And therefore, we understand it is below 45 years. And this risk also increases because there is delays in the receipt of psychiatric treatment. And we know that programs actually protects people from worsening of symptoms. But in our country, we see that the diagnosis of schizophrenia often takes place much later. And therefore, a lot of years are lost in not getting the right kind of treatment, which then increases the risk for suicide. If you look at suicide attempts, they're very common among patients with schizophrenia, and this becomes a significant risk factor for future suicides. About 20 to 40% of patients who have attempted a suicide among people with schizophrenia actually complete it on a later date. So it's again very important to understand this, that 1 to 2% of patients manage to complete their attempt in the next 12 months. So again, these become very important areas for intervention in suicide prevention. Comorbid depression again, schizophrenia is a cluster of issues, and depression can come in, and depression can come in at various points of schizophrenia. After an acute psychotic attack, that post-psychotic depression that takes place increases the suicide risk. And many studies have shown that there is an associated comorbidity of depression with people with schizophrenia, which is quite high. Therefore, there's high rates of major depressive disorders among people with schizophrenia, which can go hand in hand. So you can have schizophrenia as well as you can have a major depressive disorder. And this depression can serve as a stressor or a trigger for the suicidal behavior in someone with schizophrenia. And a review of data from 9 studies showed that nearly 60% of people with schizophrenia who had completed suicides were depressed at the time of their death. What is unfortunate is what we see is that a lot of these depressions go underdiagnosed, or they're not diagnosed, or they're not treated in time, or they're undertreated. Very often they're ignored. And one of the reasons for this is because the symptoms of depression can almost mimic that of negative symptoms of schizophrenia, where again the person may seem withdrawn and lost and in his own world, with lack of interest and lack of motivation, and therefore it can get masked, or it can get masked with the side effects of the medicines. And therefore, for a clinician, sometimes it becomes a gray area, because it's tough to say whether is this depression, or is this the side effects of medication, or is it the negative symptoms of schizophrenia that's coming. Therefore, because of this, a lot of the depression tends to get untreated. In schizophrenia, what they have seen is that hopelessness is a relatively more important factor than depression in predicting suicide. And therefore, it's important for us to check this determinant of hopelessness. And what increases hopelessness is this awareness into the illness, the insight into the illness, that what this illness is, has robbed me from, and what I probably will not be able to achieve. That itself sometimes can increase the level of hopelessness and become a predictor for a future suicide. In psychosis, we see delusions, command hallucinations, and negative content of the auditory hallucinations becoming a high risk for suicide. Now, again, for those who are not aware, a delusion are fixed false beliefs. So they're beliefs which are fixed and false. So if a delusion is telling that person that you are Superman, and why don't you just get onto a building and just fly? And the person may actually feel that he's Superman and try to fly without the intent to suicide. But that act will lead to his death. Or a command hallucination. A hallucination, again, is a perception without a sensation. So someone may hear voices when there's actually no one talking to them. So, and what if this voice actually commanding him, see, I need you to go to that bridge jump. So the person is just obeying a voice, and that itself can lead to his death. Or the negative content of an auditory hallucination. So again, that hallucination, which is auditory, which he can hear, is telling very negative, very cruel things about maybe his life, or about family, which puts him really down, makes him feel really hopeless and feels dishonored maybe. And this can again lead to suicide. But in schizophrenia, you have 2 types of symptoms. You've got the negative symptoms and you've got the positive symptoms. Positive symptoms are when you have these delusions and hallucinations. Negative symptoms are when the person is more to himself, more withdrawn. He's not able to feel pleasure. He's not able to communicate properly. He doesn't take pleasure in life. And this actually protects him from protective factor. If you look at schizophrenia, it's got various subtypes. One of the subtypes, which is called the paranoid subtype, or the paranoid schizophrenia, where the person is preoccupied with his hallucinations and or delusions, actually increases or makes this subtype of people more vulnerable to suicide. And the negative type of schizophrenia, again, is a protective factor. Comorbid substance use. So we can see people with, again, if we looked at the risk factors for suicide in the WHO manual, we saw that substance use disorders, or people with with drug abuse and alcoholism and other kinds of substances, are also at a very high risk of suicide. So, and when this substance use disorders are seen along with people with schizophrenia, this doubles the risk of suicide. Then early age of onset of the illness of both. I mean, if you look at it, we know that schizophrenia starts off early on in life, coupled with substance use, increases people to suicide. And youth who abuse drugs are at a higher risk of committing suicide, and drug or alcohol abuse is identified around 70% of children and adolescents who have ended their life to suicide. So we know that young people are more vulnerable to both substance use disorders as well as to schizophrenia. This doubles the impact of suicide ideation on to this subset of people. How do we actually manage someone with a suicide ideation? The first thing is to ensure medical management, ensure that the person with schizophrenia is taking their medication. That is very, very important. We see a lot of people actually stopping their treatments, and there's a discontinuation of medication, and that is not very helpful. It's important to thoroughly assess for all symptoms and comorbidities like depression and substance use. Do a suicide risk assessment on every visit. Regular follow-ups, monitoring patients who have survived attempts, and provide them for psychosocial interventions, which help them to build up their potentials and see life in a much better way rather than where they started from. Preventive strategies, as I mentioned earlier, it's important to ensure accessible and affordable treatments, ensure that we catch schizophrenia, this disease, much early on into the illness, so that we can start treatment early and prevent future disabilities. Psychosocial interventions definitely help people to talk, to communicate, to be a part of a cohort, a society, and to get the kind of help that they need, both at an individual level as well as at a family level. And therefore, family therapy is also very important for families to understand schizophrenia and the complexities of schizophrenia and what schizophrenia actually does in their own lives, the impact of schizophrenia on their lives, and how this sometimes burden or burnout or negative cognitions can actually impact their caregiving. It's important to provide facilities for this kind of skill building and supportive employment, so that people feel a useful part of society, and that is so important. It's the basic dignity of any human being. And definitely provisions for rehab centers, short stay and long stay homes. Healthcare workers and people generally in the community need to be basically trained in a few aspects of suicide prevention, and more specifically, maybe healthcare workers in terms of how to catch these symptoms in someone with a psychosis. One is being alert to the warning signs of suicide. Do not take it lightly. If someone is mentioning that he wants to die, and maybe directly or indirectly, even if he's playing a joke, we need to take it seriously. He may say that life is useless, I'm not worth living, what's the point in life? Statements like this need to be taken seriously. Check for symptoms like any delusions, hallucinations, which are the command type, or the way the person perceives any kind of hallucination, if it's perceived in the wrong, negative light. Check comorbidities, depression, substance use disorders, very significant, very important. please remember, and this is not really to the professionals, but to lay people, ask the suicide question. It's okay to ask someone if they're feeling like ending their life, but it all depends on how we ask that question. If it comes from a point of care and concern, where that person knows, when I'm asking this question, not because I'm belittling him, but it's because I'm really concerned about him, that question can be a huge suicide prevention strategy. Just asking that question, which many people feel so afraid to ask. And it's important to provide support both short-term as well as long-term, because we know that for anyone who survived a suicide attempt, the chances that he will complete that suicide is very high. We've seen that. Also, it's important to support families of people who have ended their life to suicide. Cooch does run a suicide stress helpline. This is our number, 0832 252525. It's presently operational from Monday to Friday from 1 to 7 p.m. So if anyone does have any kind of distress, they need to talk about it, or they're feeling suicidal and they're feeling ashamed to express to anyone else, they are more than free to call us. We have trained volunteers on the other side of the line. And thank you. Yeah, so over to Dale.
Sorry, I did not know I was on mute. Okay. Thank you so much, Doctor, for really highlighting the various contributory factors in, for persons with schizophrenia, and especially whatever contributes to suicide, and also very highlighting the important areas to address, especially, it comes very helpful in intervention and as well as the prevention strategies. Well, dealing with substance abuse, alcoholism, or drug addiction is never easy, and it's even more difficult when you are also struggling with mental health problems. I would like to introduce you to our next speaker, Dr. Abhijit Nankarni, who will shed some light on this topic. He is a psychiatrist and epidemiologist who works between the UK and India. He is an associate professor of global mental health at the London School of Hygiene and Tropical Medicine. He is also the director of the Addictions Research Group at Sangat, Goa. And currently he is the president of the Psychiatric Society of Goa. Over to you, Dr. Nandakarni.
Thanks, Dave. Let me quickly set up my presentation. And I would like to thank Peter Cooch for inviting me to this talk. I hope everyone can hear me. My brief was very simple, as given to me by Peter. Said it has to be a tiny talk, which means I have to finish things in 15 minutes. And he said I have to make it simple, easy to understand. Now, that's a difficult task, considering that we can actually write a book or several books on addictions and mental illness, but I'll try my best to cover or give you a snapshot of addictions and mental illness within a 15-minute period. What I'm going to do over the next 15 minutes is try to help you understand what I mean by comorbidity, or both mental illness and substance use disorders existing together. What is the size of the problem? Why does it happen? And what are the potential solutions to deal with this problem? So let's start off with what I mean by comorbidity or dual diagnosis, which are older terms. What we use currently, or more appropriate, is disorders, and which we will see or hear being said more often these days. And what do I mean by that? As this figurative representation shows you, it's when someone has both a mental illness and a substance use disorder. And we have to be very clear about this. It's when both of these coexist, but can be diagnosed independent of each other. So if a person has, say, for example, schizophrenia and alcohol use disorders, we should be able to independently diagnose them with all the features that are required to make a diagnosis of schizophrenia and all the features that are required to make a diagnosis of alcohol use disorders. So for example, if you had someone with, let's say, depression or schizophrenia who is drinking heavily, that by itself does not make it a co-occurring disorder. They need to fulfill all the criteria that are required to have an alcohol use disorder in order to be diagnosed to have a co-occurring disorder. So having put that aside and kind of understood what we mean by co-occurring disorders, let's look at the size of the problem. How common is the problem? Because we wouldn't be talking about it if it was not common enough. So let's look at the first circle on my left, or the left slide. If we have 100 people with any kind of mental illness, how many of those would have an accompanying substance use disorder? It's approximately around 10 to 35. So 1 in 10, or 1 out of 3 people with mental illness will have an accompanying substance use disorder. And let's look at the reverse. What happens if we have 100 people with a substance use disorder? Approximately between 20 to 80 of those 100 people also have some kind of a mental illness. That is 1 out of 5, or almost more than 2/3 of people with a substance use disorder, we also have some kind of a mental illness. Now this range is we not know for sure exactly what percentage of people with either one of those conditions has the condition. And the reason we don't have a very precise number is because these studies have been done in different countries, different samples, different settings, etc. And that accounts for a lot of that variation. But keeping this aside, if we just look at even at the range and at the lower end of the range, so to say, 10 in the case of people with mental illness having substance use disorder, and 20% in the case of people with substance use disorders having mental health problems, even those numbers are pretty big. So although there's a huge range of prevalence both of these conditions, even if we look at the smallest proportion, it still works out to a big number. And what are the substances that people with mental health problems use? And these are numbers coming from America, which are not much different from numbers that you will get from a lot of other developed countries. The commonest substance that is misused, especially in severe mental disorders like schizophrenia, is cannabis or marijuana or weed, followed by psychotherapeutic drugs, which is very interesting. I mean, medications that are prescribed for the treatment of mental health problems, such as antidepressants, or many times sleeping tablets or benzodiazepines, themselves have street value and get misused. But that's what's happening in developed countries. What's happening in India? In India, the two commonest substances that are used or misused amongst people with mental illness are tobacco and alcohol. And these are the ones which we need to focus on in our daily practice and care we provide to people with mental health problems. And what are the mental illnesses that are commonly associated with people with substance use disorders? There are quite a few. Most commonly, these are anxiety disorders, depression, and the more severe disorders like bipolar disorder and psychotic illnesses like schizophrenia. Attention deficit and hyperactivity disorder is a developmental disorder that you find in children, and many times some substrates of that manifest or persist in adulthood. And a group of conditions which we call as borderline personality or personality disorders, which are a range of different types of personality disorders. But for us as caregivers or people who provide services to people with mental health problems, the ones which we have to be most aware about are the disorders like anxiety disorders, depression, and the psychotic illnesses or severe mental disorders like schizophrenia and bipolar disorder. Let's just look at severe mental disorders and the kind of numbers that persist. So for people with severe mental disorders, approximately 1 in 4 have some kind of a substance use disorder. And for people with substance use disorders, approximately around 1 in 10 have some kind of a severe mental illness. So those are the broad numbers when we look particularly at severe mental illnesses like schizophrenia and bipolar affective disorder. So the bottom line is the prevalence of substance use disorder in severe mental illness or vice versa is pretty high. So having established what we mean by co-occurring disorders and the size of the problem, the next big question is what comes first? How are they two related to each other? Does severe or mental illness occur first and then lead to substance use disorders? Or does substance use disorder occur first and then lead to mental illness? Or do they occur together? Are there certain things that are common to this and lead both of these? So next few slides are trying to understand this a little bit better, or trying to answer the chicken or the egg question. So the first theory is around common risk factors, which basically means this, that there are certain factors which predispose to the development of both substance use disorders and mental health problems. So there's a common pathway that leads from a particular risk factor to the development of either a severe mental disorder or a mental health problem, and a substance use disorder. And what are these common risk factors? One is the genes. Some people have certain kinds of genes which work on pathways which lead to both a mental health problem as well as a substance use disorder. That's the genetic propensity to develop both, because there's common genes which have mechanisms that operate at both mental illnesses as well as substance use disorders. Then the structure of the brain. There are certain regions or the certain parts of the brain which are complicit in the development of both a mental health problem and substance use disorder. So there's a common biological substrate or a common foundation within the brain which leads to both substance use disorders and mental illness. Environmental influences. So that's the whole debate on nature and nurture. Now we spoke about nature, which is your genes and your brain. We're talking about the nurture. What are the things that happen around us which can increase the risk of both mental health problems and substance use? And one example of a common risk factor could be intimate partner violence. If you are a victim of intimate partner violence, there are greater chances of you using a substance to alleviate the distress that you experience from being a victim of intimate partner violence. And there are also greater chances of developing common mental disorders like anxiety and depression, and also post-traumatic stress disorder. Another common risk factor is stress. Stress is a very common risk factor which connects both mental health problems as well as substance use disorders. Stress or psychosocial stress can lead to a lot of mental health problems such as depression, anxiety, etc., and is also guilty in terms of getting people to start using substances and continue using substances. And finally, childhood experiences play a big role as a common pathway to the development of mental illness as well as substance use disorder. And a common example of that could be childhood sexual abuse. Young people who have experienced childhood sexual abuse are more likely to develop mental health problems and are also more likely to start abusing substances. So again, there's a common pathway leading up from childhood experiences to developing both mental illness as well as substance use and substance abuse. Let's look at the other two pathways that we spoke about. Someone starts off with mental illness and then goes on to develop addictions or substance use disorder. So one pathway for that is self-medication. If someone is experiencing distressing symptoms of a mental illness, be it hearing voices when someone is having schizophrenia, be it someone feeling low because they're having depression, or be it someone who is feeling extremely
see the
anxious
screen.
and unable to
What
function.
happened to my screen?
So if someone is experiencing these kind of symptoms, some of the substances of abuse can alleviate or help reduce these symptoms. So some of the substances that people use when they have mental health problems, like cannabis, cocaine, etc., can help reduce these symptoms. Now, the problem is that this reduction of symptoms is temporary. And in the longer term, this can lead to worsening of the mental health problems. The other thing that happens with mental illness is that it leads to certain, or it's associated with certain changes in brain activity, which then increases the vulnerability of using substances in a problematic manner. So for example, there are certain changes in the brain which happen with mental illness, which leads to enhanced rewarding effects of substances. So for example, having a mental illness and someone not having a mental illness, if they smoke a cannabis, someone with a mental health problems or which has led to certain changes in the brain are more likely to get a better effect of that substance than someone who does not have a mental health problem, which means they continue using it or use it more. If you have a mental health problem, it reduces your awareness of the negative effects of the substance. So it's, say, for example, if the substance that you're using is affecting your functioning in your workplace, or it's making you more aggressive, because you have a mental illness, it reduces your awareness of these adverse effects, and hence you continue using the substance. It reduces the unpleasant symptoms of the mental disorder, as I spoke about, which is the self-medication. So if you're hearing voices, if you're feeling low, if you're feeling anxious, the substance reduces the symptoms. And finally, certain substances reduce the side effects of the medications used to treat it. So for example, in people with schizophrenia, if you're using antipsychotic medications, and if you're using tobacco, it reduces the level of the medication within your blood. And so the side effects of the medicines are reduced. But the flip side of that is, because you have lower levels of medicines in your blood, your symptoms also are not as controlled as they would be if you were not using tobacco. And the third scenario is where you have addictions first, and which can lead to mental illness. So how does that mechanism play out? So you have substance use, which leads to certain brain changes, which are similar to what can happen in mental illness, and thus that brain changes leads to mental illness. Similarly, you have substance use, which leads to what we call as kindling, which I will explain shortly, which then in people who have a predisposition to develop mental health problems, they go on to develop mental health problems. So basically, if this person had a predisposition to mental health problems but did not use substances, they would not have developed the mental health problem. And an example of that is cannabis and schizophrenia. You might have someone with a genetic vulnerability to developing schizophrenia, but they do not get pushed over the edge, so to say, until they start smoking very potent cannabis. And that's where the kindling comes in. So put it in very loose terms, the predisposition is the fuel which is existing. So you have got dry wood, or you've got petrol, or you've got diesel lying around. But until someone strikes a match, you're not going to have the fire. And so kindling is that match. So cannabis is that matchstick which you light, and the predisposition is the fuel. And how does this combination or co-occurrence of these disorders impact people with mental health problems? So the first thing, as I said earlier, was interaction with medications. It leads to many times reduction in the levels of medications in your blood, which means that the effect of the medication is not as good as it should be. And so you might require more levels of the medication, which can then go on to increase your side effects. It increases your vulnerability to certain events. So for example, if you have got a mental health problem and you're using substances, let's say you've got schizophrenia and you're drinking alcohol heavily, there are greater chances of you being a victim of violence or being mugged, etc. So it increases your vulnerability. Similarly, if you have a mental health problem and you use substances, it increases your chances of becoming violent. So for example, if you've got a bipolar affective disorder, you are in mania and you start using cocaine, it increases your chances of becoming violent because cocaine increases your self-confidence. You're less worried about the effects of what you do and the consequences of what you do, and hence the chances of becoming violent are greater. But all round, if you have a substance use disorder and mental health problems, your outcomes are going to be worse as compared to someone who has only one of the two. And how do we deal with this co-occurring disorders? Which this is not much different from what you would do with someone who has only mental health problems or only substance use disorders. The only difference being that it sometimes requires more intensity of these interventions as compared to someone who has only one of those two. So you require psychological treatments or counseling or psychotherapy, whatever you might want to call it. You require medications, you require supported employment, you require assertive community treatment. So it's not treatment which happens from clinic to clinic or appointment to appointment at the clinic, but you need more support within the communities. You need to do, say, psychoeducation of the family because they understand what the issue is and how to deal with it. Finally, the treatment has to be focused on the longer term management and recovery rather than managing only acute effects of either the mental illness or the substance use disorder. And how do we organize these treatments? So you could have treatment happening for mental illness and substance use. Both are independent and disconnected. So you are receiving treatment for a mental illness in one clinic with one clinician, you're receiving treatment for substance use with another clinic, another clinician, another rehab home, whatever. You have both these treatments happening sequentially, and they are not connected or independent of each other. So you get first treatment for your mental illness, and when you get better, if your substance use continues, you get treatment for a mental illness, or vice versa. You could have parallel treatments which are not independent but connected to each other. So both are happening with different teams, but both teams are working together, working with each other, but they are still separate teams working on these two conditions. As you can see, there will be several limitations to these kind of models. And the best model actually is what we call as an integrated model, where both treatment for mental illness and substance use happens under the same roof, same organization, same team, same services, and that gives you the best outcome. So the take-home message from all of this that I've said today is that co-occurring disorders are extremely common, and we don't acknowledge that as much as we should. The relationship between substance use disorders and mental illnesses is complex. As I've explained, there's going to be bidirectional or both happening together, etc. The relationship is complex. But what is definite is that the outcomes in substance use disorders co-occurring with mental illness are worse for both the mental illness as well as the substance use disorder. And to avoid or to prevent or to reduce the chances of this worse outcomes, we need to provide care which is integrated, which is providing care for both the substance use disorders and the mental illness under one roof with one team. But for various reasons, such kind of an integrated care faces several barriers. Thank you very much. That's all from me in this tiny talk about substance use disorders and mental health problems. I will stop sharing my screen now.
Yeah, thank you so much, Doctor, for sharing with us. Okay, before we move on to the next set of tiny talk sessions, we will start with the question and answer round. Yeah. So the first question that I would like to put across is to Dr. Sriraj. The question is, can bipolar Vigne affliction under medication possibly lead to schizophrenia? The case background is of a mother who was suffering from schizophrenia.
Sorry, I think I did not get the question properly. Can you repeat?
Yes, I'll repeat the question. Can bipolar Vigne affliction under medication possibly lead to schizophrenia. The case background is the mother was suffering from schizophrenia.
Okay, if I have to understand, then I think the individual, when individual was suffering from bipolar, was suffering from bipolar disorder, who was on treatment, and his or her mother was having schizophrenia, and then can it evolve into schizophrenia? That I think that's the question. So there is a possibility. There is a possibility where we see many patients. The diagnosis evolving over a period of time. Nevertheless, the course might also remain the same, but it can even fluctuate. So whatever the diagnosis might be, it primarily depends on the management and the medications and the other kind of treatment that we need to take. And if the treatment are given adequately, most of the times the prognosis will be good. And I would see naming of the diagnosis, either bipolar disorder or schizophrenia, many times will be more for a technical reason rather than having a major practical bearing. So I would say, because even schizophrenia, in that sense, there are a few questions earlier in the chat box I would see that schizophrenia actually has different type of course. So I would say 1/3 of individuals, they will have one episode or two episodes and they will do absolutely fine later on. There are few individuals who will have multiple episodes and then they'll be doing much better. But there will be only around 1/3 of patients who would persist to have problem with the different symptoms like negative symptoms or other things. So that's where we find it difficult or challenging to treat and help the patient to the full extent that would be required. So in that sense, I would not be worried too much about the label that we'll be giving for the diagnosis, given that if the treatment and the patient is doing well, either with bipolar disorder or schizophrenia in that sense.
Thank you so much, Doctor. Yeah, so the next question, I will club it together. The question is schizophrenia harmful to our life? And what's the average age of onset of schizophrenia, or how do we identify the onset of schizophrenia? Can the onset be after the age of 90, or can it be confused with dementia? Anyone could answer this question. Any one of our professionals on the panel is welcome to answer this question.
Okay, I'll take that. So schizophrenia generally begins early on in early adolescence, rather later adolescence. That's a general age. But yes, schizophrenia can occur across all populations, all ages. Even at a 90-year-old, yes. The first onset schizophrenia, I'm not really sure. But I'm not really sure about that, and maybe either Abhi or Sriraj could throw light on that. But generally, it begins in your later adolescent period, you know. And how do you recognize it? Definitely, there's a change in the normal behavior of this person. He can either become, if he has negative symptoms, that he can become more withdrawn. He can lose interest in things that he enjoyed. He may stop looking after his personal, just his personal grooming, personal care, self-care can go down. He could begin to have hallucinations and or delusions. So he begin to believe things which are not true, but vehemently hold on to those beliefs. Or he may be hearing voices, basically have hallucinations in any of the forms. It could be visual, it could be auditory, it could be tactile, olfactory, it could be in any of the senses. He could believe things like, that people are following him or people are talking about him. It could be of the paranoid type. So yes, if any of these unusual kind of behavioral changes takes place, where there are hallucinations and or delusions, or negative symptoms where the person is actually beginning to withdraw, to isolate and not care for himself, we have to put schizophrenia as one of the probable diagnoses.
Right. Thank you, doctor. Yeah. So the next question that we would like to address is, all right, how do you help someone with hopelessness in schizophrenia? How can you help someone with hopelessness in schizophrenia? And also one more question is, John Nash is supposed to be able to manage and ignore the hallucinations. Is that really possible to manage the hallucinations?
I'm happy to take the second one.
Okay.
With regards to John Nash and hallucinations, yes, yes. The answer is slightly complex than a straight binary yes or no. John Nash is an unusual but not so unusual example of someone with schizophrenia who has gone on to achieve a lot, because ostensibly the kind of changes that occur because of schizophrenia in the thought processes allowed him to hypothesize or create all of the theories that fit. But to answer the question, keeping John Nash aside, the question about whether you can manage the voices, the answer, let's say 10, 15, 20 years ago would have been no. And an answer would have been no. Everyone who has schizophrenia and hears or has hallucinations need to take medications to manage that. But there is a growing movement amongst people who experience psychotic illnesses where their focus is on being able to manage the symptoms or the hallucinations without taking medications or taking minimal medications. And there's a growing evidence of various therapies. So for example, at the Maudsley in the UK, when I was kind of training there, we used to have a outpatients clinic called Voices, where people were actually given therapy or psychological therapy to help them deal with the distressing voices. There is now new research happening on using technology to help people deal with hallucinations called avatar therapy. So there are ways. It's a growing field. We still don't understand all of it, but the answer is yes. For some people, it might be possible to manage it. It all depends on the call that the patient takes, or the person with schizophrenia takes, because if it is causing them distress, and if it is interfering with their functioning, then they need to be taking some kind of care, be it medications or psychological treatment or a combination to manage symptoms. The question of what kind of treatment they need to take is dependent on the amount of distress they experience and the amount of interference these symptoms have with their day-to-day functioning.
You. Right. Yes, there are a whole lot of questions. Yes, this is for Dr. Peter. So when a person is under treatment, is there also still a risk of suicide? And is psychotic depression a symptom to identify schizophrenia?
Yeah, so suicidal ideation can crop up at any time. We know even if you look at your physical health issues like diabetes or hypertension, in spite of the person being on regular medication and having achieved good control of their sugar levels at one point in time, the sugar can still spike up. And similarly in schizophrenia, when we are treating people, in spite of them being very compliant on medication, symptoms can begin to arise. Yeah. And therefore it is very important for us to closely monitor these symptoms, to monitor both their positive and negative symptoms, as well as any mood changes, because we know that they cannot always be seen in isolation, and they do overlap, and therefore catching on a depressive mood early on will actually help to catch any emerging suicidal ideation that may come in, and actually treat them early on. You look at psychotic, what was that question? Psychotic depression?
Yes, doctor.
What was the question?
Yeah, 1 second. I will just repeat the question. Oh, yes, and I would like to add another question to that, which is very similar. So the question is psychotic depression a symptom to identify schizophrenia? And the next question I wanted to add is, what all are the major obstacles that you faced when you are working with a patient who has suicide ideation and depression and in psychotic symptoms?
Yeah, so psychotic depression is not a diagnostic criteria for schizophrenia, definitely not. But depression can emerge post psychosis or even sometimes during psychosis. You know, it can go hand in hand, and it can come in post psychosis, or it can come in at any point in the whole schizophrenic timeline. You know? So it is not necessarily, depression is not necessarily, it's not necessary, it is not a diagnostic tool to diagnose schizophrenia. That's one thing we have to understand. Yeah? But yes, any mood elements can come in along the course. How do you help someone with suicidal ideation? That was the second part, right? So the first thing is to assess what is the cause of suicidal ideation. Is it hopelessness? Is it depression? Is it some social factors that have come in? Is it some interpersonal relationship factors that are prevalent? Is it substance use that has come in over there? We need to do a full risk assessment of the suicide risk severity level. We need to assess that. We need to check what are the various contributory factors and look at each factor and then see how we can help the person. In the meantime, like a very basic tool that is used and can be used in general public, you know, is just a few questions. Ask them first, are you feeling suicidal? Yes or no? You know, that's a simple, very first, as I said, many people feel, I mean, they find it very difficult to even ask that question. Yeah, they feel that by asking that question, they're actually putting a thought in someone's mind. But if you just ask that question, yes or no, you know, if they say no, very good. If they say yes, then we want to know to what level it is. You know, have they thought of a plan? Have they thought of what they're going to do? Yeah, level number 2. Level number 3 is, do they have the means to execute that plan? You know, have they have a, do they know where, when, how, what they're going to do? You know, do they have it with them at this point? So these are the various, it's a very basic risk assessment that we can do, yeah, at a community level to pick on and actually to then give support to people who are thinking, contemplating suicide.
If I may quickly add to what Peter said about the risk of suicide and schizophrenia, I think, or for that matter, mental illness, I think what we need to keep in mind is that the risk is not only and always high when someone is acutely unwell. And that's usually our thinking. And so we let down our guard when someone with a mental problem starts getting better. Many times the risk of suicide in some, let's say, schizophrenia, especially the first time it happens, the risk increases when the patient starts getting better. And there are two reasons why this happens. One reason is that when the patient starts getting better and the symptoms go away, they have the drive to act on their suicidal thoughts. Whereas when they were unwell, they lacked the drive to go ahead and do what they wanted to do to end their life. And the second thing is, especially when young people, first episode of a psychotic illness like schizophrenia is that when they get better and they realize that this is probably a lifelong illness which will affect them for over the coming years, the whole thing about hopelessness that we've talked about all this while starts creeping in. And so sometimes they see ending their life by suicide as a way out of the years ahead of them. So we have to be very mindful that it's not when people are acutely unwell that they might end their lives by suicide, but also when people start getting better and better, they still remain at risk of ending their life by suicide.
Thank you, doctor. Yeah, so there's I think we have another 1 minute or so till 6 o'clock. So we will just take the last question. Thank you everybody for putting in your questions. Unfortunately, due to time restraints and constraints, we are unable to take all questions, but I have just one last question for Dr. Abhijit. Yeah. So the question is, can the patient harm others even without under drug influence? Is there any stats about this? Or if anyone comes across such a situation, what to do to help the patient as well as the situation? Does schizophrenia actually disappear with the discontinuation of cannabis? And to club another question onto that, there is someone who is on antidepressants for 2 years. Can I take them for a lifetime as I'm unable to get off them? The psychiatrist has recommended me Devenlafaxine, which is an SNRI for a year. I have never gone to the clinic after 1 year. I'm just taking them every day, 25 mg tablet.
Okay, Dale, that's lots of questions. I don't know whether I'll remember those. So I'll have to kind of ask you to remind me each one. So I'll take, so this is the recency effect. I'll take the last one first because it's probably the easiest to answer. So whoever asked that question about antidepressants, please go and meet your clinician, a psychiatrist, the doctor, whoever's prescribed you these medications. It might well be that you do not require, you're fully fine now, and it's quite possible that you might not require the antidepressants. And don't try to do anything by yourself, because many times, although people do not become dependent on antidepressants, when you suddenly try to come off antidepressants, you can get what are known as withdrawal symptoms, which can be very distressing. And so please go and see a psychiatrist or whoever the doctor is who has prescribed you the medication. If that doctor is not available, any other psychiatrist, and get your medications reviewed, because it's quite possible that you don't need them anymore, which would be wonderful news for you. Okay, then I'll take the first question now, because that's the primacy effect. I can remember the first question, which was about violence and mental illness. We need to break this myth that people with mental health problems are more violent than the general population, which this is absolutely not true at all. There's lots of evidence to show that people with mental illness are not at a higher risk of becoming violent as compared to the general population. In fact, they are, what we have to be worried about more is the victimization. They are more likely to become victims of violence from other people as compared to being the perpetrators of violence. So please keep that in your mind. People with mental illness are not going to come and harm you needlessly. People with mental illness are more likely to become victims of violence from other people in society, without going into the numbers. I think the other question was about cannabis. Whether someone who develops schizophrenia, which is triggered off by cannabis, will get better if they stop the cannabis. The answer is no. The course might get better in the sense that the severity or the intensity of the mental illness might be more subdued as compared to someone who is also using cannabis. But as I spoke about in my talk, it's like killing. So you got the fuel, you got the match. right? There's lots of fuel. You strike the match and you set fire to the fuel, and then the fire becomes self-sustaining. You don't need the matchstick anymore. The fire is feeding itself. And so if you have the propensity of developing a severe mental illness like schizophrenia and it's triggered off by cannabis, stopping the cannabis will not make the schizophrenia go away, but it will probably dampen the intensity of the mental illness or of the schizophrenia. Dale, I'm sorry, I don't remember any of the other questions. I mean, if you really want me to answer those, you'll have to remind me.
No, thank you, Doctor. Actually, you answered all three of them.
Oh, wonderful.
Fantastic
Then I'm not
memory
getting
out there.
I think.
Very commendable memory out there. Yeah. Thank you so much, everybody. Unfortunately, we can't take any more questions, but thank you so much to our panelists and our wonderful doctors who shared with us their knowledge. Okay, thank you to each and every one of you. We will begin the next session shortly, requesting all the other speakers to get ready. Thank you so much.
And personally, also, I would like to thank Abhijit and Sriraj for accepting to give these talks. It was, I think, really useful and beneficial, and I really thank you both.
Thanks, Peter. It's always a pleasure to engage with people when it comes to mental illness. Thank you.
Bye-bye. Peter, I think it's a wonderful opportunity that I had to interact with all of these guys. So thank you for giving this opportunity.
Thank you, Sriraj.
Okay, so let's get on to the next session where So communication is a bridge between confusion and clarity, especially with a person with mental illness. To understand more about this, I would like to welcome our next speaker for the session, that is Mrs. Janet Dias. Mrs. Janet Dias has completed her post-graduation through the Goa University. She was the former director of Coach Mental Health Foundation and is a counselor at the school and higher school level. She was a former lecturer at Nirmala Institute of Education for Post-Graduation Diploma course in Guidance and Counseling. She is a member of the Juvenile Justice Board, Mercedes, for the past 3 years. Currently, she has her own private practice. So over to you, Mrs. Janet Dias.
Thank you, Dale. Thank you, Dr. Peter and the whole coach team. Yes, so today I will be discussing very briefly the empathetic approach to communication. Just a moment, I'll just be putting up my slides. I think so I've lost.
You're on mute. You're on mute, ma'am.
Sorry. I think so that, can you hear me, Dale? Dale, can you hear me?
Yes, yes. Now we can hear you.
Yes, yes. So I think so the simplest way I could put this is the ability to put myself in the shoes of another, to see with his eyes, to hear with his ears, and to feel with his heart. It's the ability to put myself in his shoes and imagine what would it feel if I was in his situation. It's entering the private world of another without allowing myself to be influenced by my own thoughts, my feelings, my views, or my values. So since today all the topics are aimed at fostering a better understanding of this condition called schizophrenia, could we, since we are on the topic of empathy, could we put ourselves just for a few minutes in the shoes of a person diagnosed with schizophrenia and try and understand in the best way possible what would it mean if we were hearing voices, if we were convinced that those strange, bizarre thoughts were real, if we lost a sense of self, so much so that experiences seem so foreign it would be difficult for us to put them into words. What would it mean that we were struggling every day to do even the simplest tasks smoothly? So let's ponder, even as we put ourselves in the shoes of this person who's vulnerable, what would be the range of emotions we would go through? How would we want people around us to respond to us? What are those responses that would upset us further and those that would calm us? Do you think that the insight gained through this exercise would change the way we responded to a person with this condition? So what I've done is, while I was preparing this topic, I thought to myself that I put myself in the shoes of a person with schizophrenia. And I thought to myself, I think so the people I would be most comfortable with would be my family. So what I've done is I have linked this empathetic approach with the family. And I've tried to examine the unproductive ways of communicating and their effects on me. And I also tried to figure out what would be those empathetic responses that would make me feel at ease. So,
Sorry
yes.
to interrupt.
Yes.
Can you please choose from current slide and enlarge the presentation?
Yes.
Thank you so much. Sorry to interrupt.
Okay. So the first empathetic response that I would like to focus on is active listening. Because I think so this becomes the very foundation of all our other responses. Now, reminding you that I've put myself in the shoes of a person with schizophrenia. And I think so my family would want answers from me, seeing this very dramatically changed behaviors in me. And I hope that as I tried to explain to them this chaotic world of mine, they would listen to me with an open mind. They would listen to me without commenting, without judging me, without poking fun at me, without being sarcastic. Also, I would really be relieved if they did not accuse me of pretending, of making up stories, or of overreacting. I think so just listening to me calmly would help me relax, and also what would help me if they repeated some of the content that I have spoken to them. So this will ensure me that they have heard me and they've heard my story and not one that they may have read about or heard about. Now listen for the emotion and reflect what you hear using feeling words. I think so the tendency would be trying to make sense of the information I was giving them. But I really hope that they would try and focus on the emotional turmoil I was going through, rather than trying to make sense of what I was trying to tell them. It would really make me feel edified if they connected with my emotions at that point of time. And they could do this by reflecting my experiences back to me using feeling words. Like, for example, they could make statements like, you feel frustrated since you cannot do the simplest tasks smoothly, or you must be feeling so frightened to have these thoughts that you were being stalked by aliens. So you see, the focus is on my emotions, and that truly would be very edifying. Do not advise. Now, I don't think it would be possible for anyone to really fully understand the change that schizophrenia brings about in a person. Even I, if I'm just trying to understand, I don't think I would be able to really fully explain to someone what I was going through. So I think so this giving advice would only serve to aggravate me further. So instead of giving advice and trying to soothe in this way, I think so just acknowledging my experiences, not dismissing them, not trying to talk me out, but just listening very calmly, patiently. I think so this helped me feel heard, understood, and validated. And I think so once I begin to feel this way, I would be willing to trust them a little bit more, and also willing to listen to what they had to say to me. Do not jump to conclusions. Yes, how distressing it would be if, for example, they took my inability to express my thoughts and emotions as a sign of me not caring, as a sign of me being ungrateful for all that they are doing for me, as a sign of me being disrespectful. I think so they could ask and clarify. And it would be so nice if they were informed that it's the illness that is robbing me of emotional expression, and that I could come across as blunt, I could come across as unfeeling, I could come across as cold. Meet me where I am today. As a way of encouraging me or keeping me motivated, there would be a tendency, probably on the part of my family, to constantly remind me of my past level of functioning. Like, more quicker, more contributing, more understanding. But I think so this exercise of taking me to my past would actually just demoralize me further. Okay, so meet me where I am today. Focus on what I can do rather than what I cannot do. And I would truly feel encouraged if words of appreciation were spoken to me. Words of appreciation for all the effort that I was putting in through the day and each day. I don't think that a heart attack or any other physical illness would rob me of my respect. And I really hope that I'm not made to feel lesser of a person with this mental condition. It would be really demeaning if I was yelled at or corrected in, or if words like weirdo, psycho, or crazy were used while addressing me. Yes, truly heartbreaking. Now, what about if I wasn't aware of my illness, or if I lacked insight? I think so I would be frightened. I would feel threatened. And I think so I may even resort to aggressive behaviors as way of protecting myself if my family tried to force me to accept this illness when I personally felt that there was nothing wrong with me. I think so using strategies, but first keeping the environment safe non-threatening, relaxing, and even resorting to strategies like, for example, keeping a record of all those behaviors that probably made them think that I required help. I think so this would really help me keep the communication going. I think so I would feel more grounded if this connect remained between us in the family. And using the right time to sit and talk out, sit and check what was working, what was not working, how were we putting off each other, you see? Or maybe we could even sit together and agree to follow certain healthy rules, like apologizing when we were wrong, like not being too quick to react. Yes, like I repeat it once again, this would make journey more bearable. I don't think anything could underestimate the power of messages. I would be so grateful if I was constantly reminded that I was cared for, that I was not alone in this journey back to being functional, that my family wouldn't give up on me. Like Dr. Javier Amador, the founder of the Leap Institute, so rightly puts it, we don't win by the strength of our arguments, but by the strength of our relationship. Now, even as I step out of the shoes of a person with schizophrenia, let me just summarize the empathetic approach. You see, it's respectful, it's reassuring, it's perceptive, it's encouraging, appreciative, it seeks not to hurt. And I think so, any approach which has these elements would foster positive feelings in anyone. And so, how much more in a person who's vulnerable? Now, these approaches, these techniques, or these steps we spoke about could also act as de escalating techniques. If a person is agitated, I think so, just listening to that person, not reacting, just being calm, not jumping to conclusions, and the rest of them, I think so, bring down the agitation, at least for that moment. Empathy facilitates interpersonal relationships and gives rise to helping and pro social behaviors. I had asked this question earlier, would empathy change the way you respond to people? Yes, and it has been found through research that putting ourselves in the place of another person actually acts as a pause to, be trying and giving an answer or reacting too quickly, which may be damaging. Now we can choose to be empathetic. Just because we have the ability, that doesn't mean we would be using it. So, but let us remember one thing, that being and using empathy not only benefits the recipient, but also the giver. And good news for most of us, this skill can be learned. Now, I would just like to discuss just two factors since we are talking about the family and empathetic approach linked to the family. What are those two which I felt would counter the empathetic communication? One would be ignorance of adequate information regarding the condition, where on account of not knowing the reasons, the family attributing it to maybe growing up issues, or maybe just the member wanting attention, or just pure guilt. So where is the scope of empathy at that point of time? I think so it would give rise to more negative emotions and also lack of self-care in the carer. So let us look at the role of psychoeducation. Now, schizophrenia not only drastically changes or alters the life of the person affected, but also the lives of the family members who are now faced to play roles that they have never been prepared for. So, empowering them with information regarding the nature from the point of view of symptoms, the causes, the need for medical compliance, the need for medical intervention, the need for follow-ups with the psychiatrist or the counselor, and most important, effective ways of communicating with the person with the illness, what would work and what needed to be avoided. Now, what are the outcomes of psychoeducation? Realistic expectations on the part of the family, better cooperation and teamwork between the one affected and the family members, better compliance to medication, reduced relapses and hospitalization, lesser stress levels, better quality of life for both the person affected and the carer. Now, it's said that carers fall either into two categories, either of a caretaker or a caregiver. So let us see who is a caretaker. A caretaker puts the needs of the others ahead of own well-being. They feel the need to control and fix the person they care for. Caring and codependency go hand in hand. And this leads to empathy fatigue, burnout, where I may be having the best of intentions, I may be having all the information, but here if I am so tired and I'm just not making time for myself and I'm exhausted, I think so it would lead to more of irritation and impatience. Now, what about a caregiver? A caregiver empowers the person they care for by encouraging them to be responsible for their own actions. They let go of trying to control the person they care for, and very important, they make time for themselves. They take time to look after themselves. And definitely, they would have the energy to be more patient, to be more listening, right? So let us probably, even as I end my slides, maybe we could discuss putting ourselves in the shoes of the other. Thank you.
Yes, thank you so much. Thank you so much, Mrs. Dias. And thank you very much for providing the various techniques in an empathetic approach. Yeah. Also, just a reminder that we will be taking questions after all the three speakers have spoken.
Yes.
Yes. So, yes, with the COVID situation on the rise and the vaccine available, various questions on whether a person with schizophrenia should be vaccinated or not, what are the side effects to their pre-existing medication. Let's find out more through our next presentation. But first, let me introduce our speaker, Mr. Satish Suhas, who is currently working with the schizophrenia and the metabolic clinics at the Department of Psychiatry, NIMHANS, Bangalore. He has academic honors which include the early career fellowship from the World Psychiatric Association and the Silver Jubilee Award for the best outgoing student in MD Psychiatry, among several others. His research interests include schizophrenia, neuromodulation, obsessive compulsive disorders, psychotherapy, and is keenly interested in psychiatry, leadership, and academic psychiatry. Over to you, Dr. Satish Suhas.
Thank you, Dale. Thank you for that introduction. I hope I'm audible.
Yes, you are.
Yeah. So I'll start sharing my screen. I must confess that my job has been made pretty simple thanks to the excellent session by the previous speaker. Now, before I start, I want to thank Kuj, and I also want to thank Dr. Peter for giving me this opportunity to come and share a few insights on the role of COVID-19 vaccinations for persons with schizophrenia. Before I start off, let's think about a hypothetical situation. There are two patients who have turned up in a vaccination center. This situation, mind you, can also be real. There's only one vaccine left in that particular vaccine center. Patient number one is a 52-year-old person who is unemployed with 3 years duration of schizophrenia, and is undergoing rehabilitation in a halfway home, and he otherwise has no comorbidity. Whereas patient two is a 51-year-old person. He's working as a sales representative. He's the sole breadwinner of the family, but has history of diabetes, hypertension, and he's on treatment since the past 10 years for the same. If I ask all of you to just think about a minute and answer me as to which one of these two individuals would receive that last shot of vaccination available in that vaccination center, most of you would say, right, it's a difficult choice. Ideally, both of them should be getting the vaccines. But given that, the person with schizophrenia is in a rehab home, some of you might be tempted to think, okay, this gentleman who is actually going out and doing his work and he's a breadwinner, let's give him that shot. Now, if you have thought about it this way, you're not entirely isolated, but you're actually wrong. And let me tell you why. I want to actually emphasize in the next part of my presentation about the fact that people who are suffering from schizophrenia need priority in vaccination. This particular entire kind of line of argument that he's otherwise at home or she's otherwise at home or at a rehab, or they're actually because of the lockdown, they are not actually actively engaging with the society. Should we really consider them a need? You do. The reasons are as follows. COVID-19 and schizophrenia share a very pathological double relationship with each other, wherein each one contributes to another, in the sense that persons with schizophrenia are actually at a higher odds of getting infected with COVID-19. Now, these odds are as high as 6 times the normal population. Now, imagine the current situation in India, wherein we are all at risk of getting COVID-19, and just multiply it by 6, and that is the odds at which schizophrenia is likely to be affected with COVID-19. Secondly, a person with schizophrenia, if he gets COVID-19, he's at 2.5 times increased risk of hospitalization due to COVID-19. But more importantly, he's 3 times more likely to die in the coming 30 days because of COVID-19. And this particular risk, mind you, is not just related to the comorbidities that this person with schizophrenia might have. It is not just related to the fact that they have diabetes, they have hypertension, maybe that's what killed them. No, there are well-designed studies which have looked into what has been going on around the globe and in the US, which have now taught us that even after controlling for factors like diabetes, hypertension, and obesity, persons with schizophrenia are actually at an increased risk of mortality with this virus. Now, they're at an increased risk of getting infected, they're at an increased risk of hospitalization, and they're at an increased risk of vaccination. Sorry, they're at an increased risk of mortality. Now, this brings us to the important question that yes, they are vulnerable, and therefore, we need to look into what are all the factors that play a role in this vulnerability. Number one, persons with schizophrenia suffer from what is called as a cognitive impairment. It is not easy for them to take decisions like me or you. Sometimes there is a certain degree of ambivalency about taking decisions. They're able to actually take all the factors into equation. Their capacity for foresight might be impaired, make it very difficult for them to actually preemptively, proactively take decisions in their healthcare needs. They're also not aware of the risk as much as you and I would be aware, purely because of the fact that they are actually deprived of the necessary information that is needed for them to take these decisions. It is also observed that persons with schizophrenia have difficulty in following COVID-appropriate behavior, and sometimes there is an interaction that is seen between the patient's active psychotic symptoms and which can lead to some negative beliefs about the vaccine. People with schizophrenia can sometimes believes that this vaccine might be the masterstroke of some evil genius who's trying to harm me, in which case I'm not going to go for the vaccine. Or they might have this which is actually coming in the ear and telling, don't see, it's actually going to kill you. So in which case it becomes extremely difficult for them to take this decision about the vaccination. Sometimes if schizophrenia is fairly advanced, there can be what is called as disorganized symptoms or negative symptoms, which will make the person lack the drive to undertake these healthy behaviors. Additionally, they are also vulnerable because of the immune mediated and the neurohumoral related factors that are happening in their body as a result of the schizophrenia illness per se. Because of all these reasons and the fact that they also suffer from comorbidities like diabetes, hypertension, obesity, which in itself are independent risk factor for getting a severe disease if one gets infected with COVID-19. Additionally, persons with schizophrenia have difficulty in getting access to healthcare. There might be socioeconomic deprivation, and they might be actually institutionalized during this lockdown or during this particular past 1.5 years, which makes it difficult for them to get the vaccine. They might be on medications like clozapine, which can have some interactions with white blood cell count, which can actually make more vulnerable to get this particular illness. And if we look at the fact that, yes, if they are so vulnerable, are they being given priority? Are they actually being vaccinated? Are they actually taking their vaccines the world over? If we look at the data that is coming in from UK, the United Kingdom, we can see that persons with schizophrenia and people with learning disability are the only two groups of people which had the lowest utilization of the vaccine resources of the country. Now, this is astounding. Now, if you look at it and if you compare it to having other organic kind of conditions, their vaccine utilization seems to be perfectly okay. But people with schizophrenia and people with learning disability and intellectual disability, it seems to be fairly, the gap between the need for vaccination and them actually taking the vaccine is pretty high. To address this particular gap, there are a few countries come forward and said that, yes, we do need to actually kind of go forward and prioritize persons with schizophrenia to receive the vaccine. Countries like the UK, Denmark, Netherlands, and Germany have actually said that we need to make them a priority group for vaccination. Just like how in India we have made people greater than 60 years a priority group for vaccination first, healthcare workers as a priority group for vaccination. Similarly, people with psychosis and schizophrenia need to be made a priority group as well. This particular statement, which I just made, that they need to be made a priority group, is based on the sound principles of ethics of vaccination, which says that when it comes to vaccination, there should be equal concern for all prioritized persons. So we shouldn't be actually saying a person who is young and who is having some diabetes or hypertension should actually deserve the vaccine more than a person who is young and otherwise having a schizophrenia illness. There should also be efforts towards mitigation these inequalities to the disadvantaged groups. And that is where this particular short talk will actually help, at least to a certain extent. Now, if we look at the vaccine platforms that are available, there are various kinds of vaccines that are there. There is a whole lot of information on the websites. But then how do we actually really make sense of it? To make the job simpler, to make it more easier for us to understand, I have actually listed what are the 3 main vaccines that are likely to be available in India at this point of time. They are Covishield, Covaxin, and Sputnik 5. Covishield and Covaxin have shown to be safe and efficacious, and their efficacy is anywhere between around 70 to 80%. They are actually shown in human trials to be well tolerated. As for Sputnik 5, there has not been any particular Indian studies to show that they are safe, but studies done in Russia are reassuring, and they are supposed to be more efficacious in nature, but we need to wait and watch as to whether they actually translate to real world effectiveness in India as well. So the next question that people might ask me, in fact, most of my patients ask me, most of my patients' caregivers ask me, so which vaccine to choose and when do we actually give the vaccine? To answer this question, I will use the help of a donkey. And this donkey is called as the Buridan's donkey or the Buridan's ass. This is actually a philosophical argument that is kind of often quoted, wherein when we think about a very rational donkey, now this particular donkey is very rational, and this donkey is both hungry and thirsty at the same time. wants to both eat the hay and as well as drink the water. But because it is taking rational argument based on the fact that, I am also hungry, I'm also thirsty, what I be doing, this donkey actually fails to take a decision and therefore continues to remain hungry and thirsty. So when my patients usually come to me, I give this example and I tell, often lack of taking a decision can lead to catastrophic consequences. So our decisions should not be, our indecisions rather should not lead to catastrophic consequences. And therefore, rather than going on an endless search in the news media, endless debates with people about whether to take Covaxin or Covishield and remaining unvaccinated, I suggest to my patients, why not go for anything that is available and anything that is available in the immediate priority so that we are avoiding any untoward incidents. Next question that my patients and caregivers often ask is, are there any interactions between the medications and the vaccine? A simple answer, no. There are no significant interactions between the medications and the vaccines that are given in India. Slightly complex answer is mostly no, because antipsychotics have been known to have immunomodulatory effects and can reduce the potency of the vaccine or the efficacy of the vaccine. Clozapine, which is a medication that is used in fairly resistant schizophrenia, can sometimes be associated with decreased white blood cell counts, which is why people with schizophrenia who are on clozapine are actually repeated with this particular investigation called as total leukocyte count and the differential leukocyte count. And also, sometimes post-vaccination, there can be certain degree of neuropsychiatric disturbances like fever, irritability, some amount of confusion, some amount of tiredness, some amount of worsening of symptoms, but they are temporary in nature. So if you ask a question, can the person who is on XYZ medication take vaccine? The answer is yes. The next question that sometimes people ask, I'm a caregiver. Of course, I want to give my relative the vaccine who is suffering from schizophrenia, but he or she does not want to do it. What do I do? And this is where we need to actually think about some possibles to the impasse. Now, decisions involve to preemptively involve the person who is suffering from schizophrenia in all discussions and in all decision-making processes regarding their vaccination and their health. Now, this brings a very important component of addressing their fears and their anxieties. When they say, if they say that, I don't want to get vaccinated, you need to just sit down and instead of advising them, which is exactly what my previous colleague who actually said that shouldn't be done, that's precisely what shouldn't be done. You shouldn't go to them and say, you know what, I have seen enough news, I've heard enough things, I even in fact attended a talk in Kuj, I know the best, you're just going to get vaccinated. No, that doesn't work. What works is using this opportunity to speak to them and ask, what is it that is exactly that you're afraid of? Are there any anxieties that you're actually having right now? And trying to rationally reassure them about anxieties and trying to kind of help them through this process of taking the decisions about the vaccine. So make the person an integral part of the decision because it is his body and it is his right. You can also lead by example, wherein you tell this, you know what, I understand it can be scary and can understand that you might be worrying about which vaccine to take, what will happen to you. Let's do one thing. Let's kind of work on this together, decide together, and I will come with you. I'll also take the vaccine shot with you myself. So if the caregiver takes this decision of modeling or leading by example, sometimes it is easier on the person with mental illness to actually take that decision. Despite that, if the person says, no, I don't want to take the vaccine, then you might actually possibly want to involve the person with whom the person who is suffering from schizophrenia has the best rapport. Try to talk to them, try to talk to people who have best rapport with the patient and try to see if they can actually kind of give the enough information to the patient so that they're actually able to take that particular decision. One more important opportunity which we have is to make use of the advanced directives. Advanced directives is where a person with schizophrenia who by and large at different points of time during the illness might actually have fairly good insight. In fact, he might have perfectly good judgment capacity. So it would become easier if you actually sit down with them and while they're actually in a relatively better state, even though the vaccine might not be available in your nearest COVID vaccination center, to talk to them and say, listen, they say that there are these 3 vaccines available, and then what do you think that you should be taking according to what do you think is the best? And if they say that I want to go for X or Y or Z, have a personal diary or a note in which you can ask them to write it down and say that, I want to actually go for this particular vaccination. Or else let them take that particular decision. If it will make it easier for you, even if they have a relapse symptoms or a recurrence of symptoms, to tell them that we had this discussion and you said that you would go for that. Are there any other new concerns that you have which I can be able to address, which makes it easier for them to accept healthy behavior such as going for the vaccination? If all of these fail and the person continues to be in a severe breakdown and there is a severe worsening of symptoms, compulsory vaccination can be the last resort, especially if they are elderly, they have a lot of comorbidities, and that they are likely to be in a state where they are going to get exposed to COVID-19. So the take-home messages from this presentation, from this short presentation, are that we as mental health care professionals, as caregivers, as patients, need to stay up to date with the recent guidelines. There's a lot of information overload. We need to simplify it and make things simple for ourselves. We need to liaise and network, find ways and avenues in which we can take help from the community, from society, from the networks, social networks that we are involved in, to find out as to where are the opportunities for us to get vaccinated. We need to also kind of engage in vaccine advocacy. Now, if you're a caregiver and you got your relative vaccinated, you need to kind of give a resounding kind of a thumbs up and say yes to other caregivers in the care groups who might be hesitant. You can help address that vaccine hesitancy. Then, additionally, secondary prevention also becomes important, wherein we need to kind of promote some adaptive healthy behavior in people with schizophrenia in the form of healthy lifestyle, physical exercise, healthy diet, so that if we reduce the burden of comorbidities like diabetes and hypertension and obesity, the risk with COVID-19 further reduces. And when you have subsequently also, if you have a lot of difficulty in trying to engage the person with mental illness towards taking this decision about vaccination, help a mental health care professional, but keep in mind, patience, rapport, and effective communication holds the key to help take the right decision. On this note, I want to thank you once again for your patient listening. I want to thank the organizers of Food for the opportunity to share some information on vaccines in schizophrenia.
Thank you, Dr. Suhas, for such an informative session, and also conveying to all of us that it's very important to prioritize vaccination, especially for this particular group of patients. So thank you so much for the same. Music has been known to have its own healing properties since ancient times, and it still continues to be used therapeutically. We now have our last speaker for the day to share with us about music therapy as an intervention for schizophrenia. I now introduce Dr. Margaret Lobo, who is a clinical music therapist and has been awarded a fellowship from the Royal Society of Arts in 2007. She's also the founder as well as the advisor of Ashwas Music Therapy and Wellness Advisory Services, LLP. The Prime Minister of Great Britain honored Margaret with a Point of Light in 2018. She dedicates her knowledge and expertise to India, providing music therapy through an extraordinary range of projects designed to help people with physical, psychological, behavioral, and learning difficulties. Dr. Margaret Lobo, over to you.
Thank you very, very much. It's indeed a great honor to be here. My husband was Goan, and I'm now settled in Goa. I've been here isolated for 2 whole years, so it's been quite a journey. I must say this evening's presentation by everybody has been absolutely superb. And I go away learning so much. And with Dr. Jeanette Dias, if she were here and we were in person, I would give her such a big hug. Because throughout 35 years of working with mental health in the UK, and also working particularly with neurological conditions, What I made from the very beginning, I started music therapy as a mature student, and I was accepted by the Guildhall School of Music and Drama in London. And when I qualified, my first job was mental health. Now, I was put in part of my training, I was put with a music therapist of many years of great experience working in what we called then a mental institution. And it was a building that was approximately 100 to 150 years old. It was absolutely dismal. There was no thought put into the building of rehabilitation, of helping. And my first day, I stood outside a room which had about 30 people in. Some were with dementia, some were with depression, some were with schizophrenia, and they were lumped together in a group of 30 people. Some were crying, some were doing circles in the room, and just moving around. Nobody was interacting at all. And I thought, my God, what have I got myself into? What do I do? So the music therapist said to me, the only thing you don't do is never turn your back on anybody. And that didn't help by any means. And so we went into the room, and of course, being a new person, they were quite interested. Some didn't pay any attention. They were moving chairs, tables. It was pretty terrible situation. No care whatsoever being given, other than being put in this enormous room with no character, no warmth, no humanity. And the music therapist sat down and started to play the piano. And I could not believe my eyes, because within minutes, people were paying attention to the music. And I made a sankalpa, and a sankalpa is a commitment. It's a Sanskrit word to surrender, to commit. And I made at that very moment a sankalpa that said, if I ever see the person in front of me as anything other than the same self, I will quit this work. And in 35 years later, my passion and love for work and the wonderful people I've had a privilege to work with is very, very powerful. And I'm here to serve as much as I can Ashwas and our wonderful team of trainee music therapists and qualified music therapists to serve the community, and to serve the community with expert training, but also with love in their heart and total commitment to making this work really for the people, and for the people who are so longing to have something they can identify with, which is music. So I just wanted to thank all of you for giving me this privileged opportunity. And now what we'll do is look at the presentation. I'm going to keep it very quick because I understand we're a bit running behind. So if we look at the first, so we are Ashwas, our music therapy for well-being, and we hope to set up in Goa within the next year and a half, the very first music therapy wellness center in India, and that will be for the community. So we'll carry on to the next one. Now, what I'd like to say is we are all musicians, we are all composers, and we can all write poetry. And you see this again and again when you're working with people with any kind of disability, that once they find a way of expressing their feelings, you're on the road to finding inner peace as best as we can. So I'll show that later in the next graph. Now, at any point, and these figures are out of date, which actually really disturbed me, that these figures have not been updated in about 10 years. Now, that shows to me a lack of care about the fact that we are growing with a lot of mental health issues, and they're not being recorded. And I think that is a great pity. But when I took these figures, it showed there were 3 million people in India suffering from schizophrenia. And that is 3 in 1,000 in a country of more than 1.25 million people. Now, there are lots of treatments. There's medication, antipsychotic medication. Psychotherapy is also seen as a very important adjunct therapy to deal with some of the symptoms associated with schizophrenia. Thank you, Yamini. Next slide. Now you say what I said. When somebody, I worked in a corporate for 25 years, and I was talking to a musician one day, and having been an opera singer and a performer, she said, "Why are you working with the corporate? You should be doing music therapy." And I said, "Oh, what is that?" I had no idea. Now, this is a brief definition. You can read all of this later. But music therapy is defined as the use of the unique properties and potential of music in therapeutic situation for the purpose of helping to modify, and I really emphasize that word, to modify human behavior so that the individual affected will be more able to function as a worthwhile member of today's as well as tomorrow's society. And that has come across very clearly by every speaker today, that their heart and their love for the person with whatever condition they have is paramount. Thank you. Now, music therapists are very strictly trained. We are trained to do research, and our clinical practices have proven to be effective with people of all ages and abilities. I think I work starting with women, a group of women who were pregnant to when they had their babies. Then we had other baby groups. Then we have children in special and mainstream schools. And then you go on to the young people and the young people with substance abuse, sexual abuse, a lot of problems. And then you go on to families, and then you go on to elderly, and then you go on to dementia and Alzheimer's. So there's nothing that music won't be allowed to work with. And we work in schools, day centers, hospitals, probation centers. We've set up a special project for young offenders in Delhi. And, it's very important that we reach people who want to have a better quality of life and deserve it. Thank you. So I'd like to just point out a few of these things. The inability to focus consistently on relevant stimuli and the inability to filter out irrelevant stimuli are schizophrenic characteristics, such as we've been hearing about today. Now, what we found with music therapy, and this has been proven through research all around the world, music therapy has a high level of subjective acceptance among patients. We started with a group of young people, and fortunately the government supported it for 3 years, and they were asked, would you like to do sport or music? Every one of them said music, which was quite a surprise. I thought they would say sport. There are no negative effects have ever been recorded, despite the therapy being introduced in the post-acute phase with schizophrenics. The post-acute phase, we're in the most desperate, and you find how to use your music through your training in psychology and psychiatry on the course. The positive therapeutic effects, relaxation, activation, reduced anxiety, easier contact making, and I'll show you a group in a few minutes where that is being done, and opportunities for emotional expression. Clients often come to music therapy with little or no self-confidence. What many would consider a basic task, like just getting up in the morning or preparing meals, having a bath, taking any hygiene care of themselves, extremely difficult. Music therapy helps clients break out of these catatonic states in ways they couldn't do so before. Now, next one we'll skip. You can look at that after. But what I would like about now is a group in London that worked together, and they started with drum circles. Drums have that great effect on people that they might not want to touch or feel they could never play an instrument. But I've never met a human being yet that couldn't play a drum. So I'd like you to look at the body language of these people. They're all very mixed, ages, cultures, languages. It's all mental health. And this is a research program that has been done. And this is just a short clipping to give you an idea of what a group session can be like.
From the psychological scales, we found that 10 weeks of group drumming led to decreased average of 20% in anxiety and 38% in depression levels. All of these improvements were found to be maintained for 3 months following the end of the intervention. We found that a single session of group drumming led to decreases in stress hormones and improvements in immune function, and the entire 10-week intervention led to reductions in levels of inflammation in participants, which is the same finding as in drugs and psychological studies looking at mental health.
Thank you. And we'll go on to the next slide. Now, what we use in music therapy are interventions. And you always have the connection between the therapist and the client, whether it's one-to-one group or a large group. Now, improvisation whilst playing instruments can urge emotional expression. So you do not have to be a musician to be able to improvise. Socialization, exploration of various therapeutic themes. So you make up a theme: conflict, communication, grief. While talk therapy allows a person to speak about topics that they may be difficult to discuss, lyric analysis introduces a novel and less threatening approach to process emotions, thoughts, and experiences. So you will often find somebody who cannot express abuse, cannot express depression, cannot express what's going on in their mind. You can find ways through the music and the music therapist to enable that to start to happen. They're imposing. Because it's rhythmic, music engages the neocortex of our brain, which calms us and reduces impulsivity. We often utilize music to match or alter our mood, and there's probably not one of us here who hasn't used music as a stimulus one way or the other, through lack of sleep, through tension, sadness, grief, anger. To alter mood states, a music therapist can play music to match the current mood of the person. Play music can be on an instrument or it can be recorded. And slowly shift to a more positive or calm state. So you can choose your music very carefully and move it to the state that will help the person the most. Now, Dr. Jeanette spoke about writing. Now, songwriting provides opportunities for expression in a positive, rewarding way. Anyone can create lyrics. La, 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 la. You know, you just made up. We always made up music as a child. So anyone can create lyrics that reflect their own thoughts and experiences, and select instruments and sounds or voice that best reflect the emotion behind their lyrics. And lastly, I would like to speak a little bit about Ayurveda, because my husband and I have been working with Dr. Corder in Goa for now almost 20 years. And it gave him 10 extra years on his life. And here I am still at my age, so I'm very grateful for it. Now, we must not cut out allopathic medicine. That is not what we're talking about here at all. You must stick to what the doctor has prescribed and work accordingly with therapeutic balances. Now, Ayurveda has been used for the treatment of schizophrenia, a long-term mental health condition, since its formulation in 1000 BC. Now, I had no idea of that, and I'm sure that is quite a surprise to all of us. Western-style medication using antipsychotics and hospital treatment is nowadays mainly used. So currently there is no cure for schizophrenia, and I'd like to say with music therapy, we are not music therapists out to cure anything. All we can try and do is that person find a finer, happier quality of life. But illness can be successfully treated and managed. And although studies are limited, ASHWAS, in every project we do, will ensure research to study the connection between allopathy, Ayurveda, schizophrenia, and mental health are always followed. So everything is monitored, everything is registered, and that is absolutely vital. Otherwise, how do we prove how music therapy works? Thank you very much. And now I'm going to finish, going to cut it a bit short, maybe just 1 minute. But I'd like to give you all a moment, because we've heard a lot today. Find music for yourself. And I chose this piece of music. I get feedback from people saying it made me feel sad. Somebody else said it made me feel happy. Somebody else said it made me feel happy and sad at the same time. Now, this is just an exercise. We use a program called guided imagery in music, and we're the only country outside of America that is allowed to use this now in our training program. I would like to give you an example, and this we use quite a bit in our work, particularly our workshops. Now, I would like to stress that when I have used this in the UK, you have to be very careful that you choose music that will not put someone with a mental disorder back into a state of psychosis. So we are very well trained to know exactly what music to use for the condition of the people we work with. So what I would like to do now is finish off, and like you all to just sit quietly in your chair as comfortably as you can, with feet flat on the floor. And then just allow the breath to fall still. Close the eyes and let the music take over. Could you put the volume up a bit, please, Yamini? Thank you very, very much. It's been a great privilege. Thank you.
Thank you so much, Dr. Margaret, for sharing with us your expertise. Yeah, that was such a peaceful and a very relaxing session towards the end. We now have time for questions. So there is a question for each of the speakers. Yeah. So my first question would be to Mrs. Janet Dias is this. I personally feel that only caregivers can empathize. How about the friends, relatives, and colleagues who do not know the condition of the person?
We would always try as much as we can to involve the whole family. In fact, we're doing that. We're pioneering a program here in India with a lady who has depression from childbirth, and she has postpartum depression. And what we are doing is working with her. Then we're having regular meetings with the father, the husband, so that the husband and the therapist know how things are developing. Because once you leave the music therapy room, the person goes home, and you want to make sure that you're allowing yourself to work and bring in the family. So eventually, your focus is on the woman. And then eventually, when time is ready and seems to fit, you would start involving the husband and mother, and the husband and the wife. Then you would start to bring in the children. And you would set a period of time. It could be a month, it could be 3 months, where you work together with the whole unit. And so you work according to the need of the person. Now, if we were working in a hospital setting with schizophrenia, if the hospital would allow it, then you could start working with the family members also. But it would be very carefully done in long solitude.
Yeah, but
Yes?
please close the front door. A lot of mosquitoes are coming in.
Thank you for warning us. Yeah, over the mosquitoes. And yes, Dr. Margaret, thank you so much for sharing with us about, yes, how important it is to involve the family, because they are definitely a part of the patient's treatment plan, definitely, and they are part of the patient's environment and responsible for the same. So it's very important that you involve them as well in music therapy. Also, another question similar to this as to, do you think that, I think this is for Mrs. Janet Dias. So yes, do you think that, friends and relatives and colleagues who do not know the condition of the person, do you think that they need to be aware about empathy and how to empathize? Is it important for them as well?
Yes. Yes, it would be important, but I think so. Empathy is also, we are actually endowed with this ability, right? Just being sensitive, like even for example, co-workers or friends or relations, knowing and being sensitive what to talk about and how to talk about a topic or when to talk about it, right? So even if the co-workers notice something awkward, not really pointing out to listen. Yes, so I'm talking about sensitivity here. And empathy is universal. It's not only meant for people with a condition, but I think so it improves any relationship, right?
Yes, definitely. Also, you have one more question. Can people with schizophrenia really take advantage of our empathy?
See, like I mentioned to you, the role of a carer who takes on the role of a caretaker, right? Where there are no boundaries, And I think so, just knowing how to put up boundaries, very gently putting them up. Yes, there could be times where the person could be taking advantage. Yes.
Okay. Our next question is for Dr. Suhas. Is there a problem with getting vaccinated and being on medication for schizophrenia? Would there be a reaction to the same?
It's an important question, and it needs to be answered. And considering that, especially persons who are suffering schizophrenia are often on multiple medications, and their question is, would it react with the vaccine? Would it reduce its efficacy, or would it make it dangerous in some way? The simple answer is, first I'll address the safety issue that to the best of our knowledge until now, and millions of people all over the world have been vaccinated. And to the best of our knowledge, there is no danger with taking vaccination while taking the medications per se. Now, with respect to the efficacy component of it, when we say that, yes, taking medicines for schizophrenia, would it actually kind of reduce the efficacy of the vaccine? There is some evidence that might be so, but the resounding support towards taking the vaccines despite being on medicines for schizophrenia is something that we have to keep in our mind. So anybody who is on medicines, please do continue your medicines on time. There is no need to skip any doses. Go for the vaccination as scheduled, and it is definitely going to help you in the longer run. But I have another comment. If it is okay, Dale. So Dr. Lobo, I felt contemplative and then hopeful after listening to your music. Thank you. It was really wonderful.
Yes, very soothing, very soothing.
Yes, very much.
Thank you so much. Yeah.
Yeah. Thank you, Dr. Suhas. So, yes, Dr. Margaret, we have a question for you. Is it possible to provide music therapy even though we don't have any knowledge in music or music instruments?
We're all born with music. You're born with sound. It's sound that brings you to life in the womb, outside of the womb. You see, you can have a musician come and they will have very set ideas. This is what I'm going to do with my music therapy. And you just let all of that go. Absolutely let everything go and come back to you, yourself. And the people that really, love this work, love doing it and keep coming to their sessions is because they discovered something in themselves they didn't know they had. They didn't know they could write a story about themselves. They didn't know that with the help of the therapist, they could put it to music. I had a group of 17 women who suffered from domestic abuse. And I sat them all down on the floor. We got a great big piece of paper. I said, I want one word from each one of you. And it was love this and happy this. And it was very nice and very sweet. And I said, okay, we'll put that aside now. Tell me the truth. Being spat at in the supermarket, called a bad mother, all of the negative side came out. And, you reach into a person and all the truth comes. You cannot tell a person to be truthful. They have to find it within themselves. Now, these women ended up, we put it together in a sort of poetic way. We gave it to one of our music therapists. He's from Brazil in UK. He's worked with me for over 20 years. And he and a couple of musicians put it to music, and these women learned to sing it. We held a Christmas concert, and the 17 women got up and sang their song from memory. And, that moment is never forgotten because you are with other people, you have created something special. And we find with young people, particularly with psychosis, they find my God, I can do this. I didn't think I could. I think I could play. I didn't think I could make music. And so music is innate in every human being. Everything we do is rhythm. You know, you can't move without rhythm, and you can't move, you cannot have sound without it arising from silence. And that is what's so important. So it's in all of us. And let's get it going and having a lot of fun and really helping people.
Thank you so much, Dr. Margaret. It was such a relief to know that, you know, all of us have music in us and have our own rhythm, and we do not have to learn music prior to understand music on its whole. So thank you so much for telling us about that. Yes, this is another question for Ms. Janet Dias. So the question is, how do we overcome caregiver burnout effects?
Like I mentioned, you know, taking care of your sleep, your nutrition, not get disconnected with your own life. You may have hobbies in the past. You may have had your own life. But so what happens is we suddenly give up on everything, which is very, very unhealthy, right? So really making time for ourselves. And like I mentioned, you know, it's not actually taking over your loved one. And because there are chances of him going into that sick role, oh, I cannot do anything, I'm so helpless, right? Empowering him by letting him do and taking over and letting him continue on the road to being functional. So, yes, having a support system, having your hobbies, and trying not to disconnect with the life that you had before, not giving up. Yes.
Yes, thank you so much. Thank you so much, Janet, for telling us that. Any more questions? Any more questions that people would like to ask? Yes. I think there's one more question for you, Ms. Janet Dias. How to talk to a loved one who wishes to move to another city to work and live alone?
I think so. First, really respecting his point of view and not really struggling and, you know, arguing with him, really sitting down and talking it out. Talk it out and talk about probably the reason for wanting to move out. Yeah. And talking about probably ways that, and if he really insists, then looking out for ways where, you know, you can build up a support for. But I think so it starts with really sitting down and really understanding his point of view. Yeah. And like Dr. Suhas had mentioned in his talk, I think so getting people who, I mean to say, are close and who this the family member is open to, maybe getting them also and seeing them as potential resource people. But like, you know, this fighting and arguing and forcing down your, it never helps. It never helps. Yes.
So, Dr. Margaret, there's a question for you. Yeah, so one is somebody is very interested in getting your contact details, if it's possible for someone from your team to put it up on the chat. And someone has asked about, is there any course in music therapy? Or where does the person study music?
Thank you. Thank you. 12 years ago, I was asked to bring music therapy to India. And because my husband was going and we had traveled a lot around India for over 30 years, I was asked by a father of an autistic child, please will you bring your work to India, because there is no clinical training people will say, I'm a music therapist, I go and play a raga. Now that's wonderful, it will help. But do you have any ability to work with someone who is autistic, who is dyslexic, who has cancer and only a matter of months to live? You know, you have to have proper training. So I decided the most important thing was to set up a postgraduate diploma in clinical music therapy. We've been doing for 12 years, and we are voted by the World Federation of Music Therapy now as one of the most important training programs now in world in music therapy, because we have based our work also very culturally around the countries we're working in. And at the moment, we're doing everything online as much as we can, because it's very important that because you have this condition around the world that you do not stop supporting people. So we have set up short-term training programs, which you can do online, graduate diploma, which we hope will be able to open up, but at the moment it's going to be online. So if you look up, I think Dr. Peter has my details, and the details are on the graph that you've shown there. If they contact us, you don't have to be a great musician, believe me. I was not anything other than a good singer. But what is important is that you have a basic knowledge and love of music. We do teach music on the course. We teach the guitar, we teach the ukulele, and people who have no keyboard skills, we help them so that you can go in. You're not there to learn how to be an instrument. You're there to learn how to use your instrument effectively for the person that you're working with. So yes, please, our courses, we do a 30-hour course online and a 15-hour course online. We also set up a project for an organization called Winnage, where we are training carers how to care for people and not burn out. So I think that's also very important. So we work with the carers. The carers can take the work that we have helped them with into work with clients. And that has proved very beneficial, because that is a very demanding job, extremely so. Thank you.
All right. Thank you so much. I think that is the end of our questions. Yeah. So thank you so much to each of the speakers who gave us different inputs and different perspectives. So thank you so very much to each one of you. And before we end this program, we will just show you a short video. Yeah. So stay tuned, everybody. Thank you so much once again to all the speakers.
Thank you, Coach, and thank you, Dr. Peter, for this opportunity. It was wonderful learning so much here, as much as I was able to share. Thank you.
Dr. Sunak, for agreeing to give this talk. I'm sure it's been really beneficial, learned a lot. Also, thank you, Dr. Margaret and Janet, for being, for accepting to speak at the symposium of us. I mean, we feel really blessed to be enriched by the lovely inputs that you all have shared with us. Thank you so much. Yeah, and as I think Dale is putting up a small video, it's a short film on schizophrenia. She will also remind us that tomorrow is a debate and a discussion from 10:30 to 1 in the morning, and we invite everyone to attend tomorrow also.
Can everybody hear and see? Hello?
No, Dale.
Okay, 1 second. I will just,
No.
yeah, 1 second. I will redo it again. Apologies, everybody. Now, can you see?
No, Dale.
You can you see it?
We can only
No, Dale.
No,
we can only we
No.
cannot see.
Now, can you see?
Yes.
சத்யா, ஏய் சத்யா, டேய் வாடா, என்னடாச்சு? சத்யா, சத்யா.
நீங்க சொன்ன மாதிரி அவனோட ஆக்டிவிட்டிஸ் எல்லாம் எழுதியிருக்கேன்.
Is there any improvement?
அதை நீங்க தான் பார்த்து சொல்லணும் டாக்டர்.
Okay. The pills are doing what they should. That's good. That's really good. It's great actually.
இதை எப்படி டாக்டர் இம்ப்ரூவ்மெண்ட் சொல்றீங்க? அவன் வீட்டை விட்டு வெளியவே போக மாட்டேங்கிறானே. அந்த எண்ணமே அவனுக்கு வரலையே.
ஆனா இன்னைக்கு வந்திருக்கா. And that's a good start. Now here comes the tricky part. He needs to step out and face the world. Find some reason, any reason. But make sure he goes out. It's the only way.
எனக்கு அவனுக்கு தெரியும் டாக்டர். கண்டிப்பா வர மாட்டான்.
Kashtanda, the pills are going to help you do this. Make sure he takes them regularly. You know he doesn't like being alone, especially outside. But you have to do this for his sake.
என்னால தனியா போக முடியாதுமா. ஸ்டாப் வரைக்கும் தானே வர சொல்றேன்.
சமைச்சு உனக்கு பேக் ரெடி பண்றதுக்கே எனக்கு டைம் சரியா இருக்கு. என்னால வர முடியாது.
தனியா போக முடியாதுமா.
அப்போ உன் அண்ணனை வர சொல்லு.
அவன் கீச்சான் போ. ஒரு ஹெல்ப்பும் பண்ண மாட்டான். எப்போ பார்த்தாலும் ரூமை பூட்டிட்டு.
Hey, no ஓவரா பேசுற. You can't accuse me like that.
அப்போ வா கூட. ப்ளீஸ் அண்ணா. தனியா போக பயமா இருக்கு.
If you ever say it again, அம்மா கூட பார்க்க மாட்டேன்.
டேய், அவளை பஸ் ஏத்தி விட்டுட்டு தான் வரேன். பாதியிலே ஓடி வந்த எனக்கு ஃபோன் பண்ணி சொல்லுடி. அவனை வீட்டுக்குள்ளே நுழைய விட மாட்டேன்.
என்னோட திரும்பி வரியா?
டேய் சத்யா, அவ ஹால் டிக்கெட்டை விட்டுட்டு போயிட்டாடா. கொண்டு போய் கொடுத்துட்டு வந்துடுறியா?
நான் போக மாட்டேன்.
டைம் ஆச்சுடா. ப்ளீஸ்டா கண்ணா, கொடுத்துட்டு வாடா செல்லம்.
டேய் சத்யா, எப்படிடா இருக்க?
மா,
என்னப்பா?
you don't look well. நான் பார்த்துக்கிறேம்மா.
Are you sure?
I'm meeting Vinod anyway. I'll be fine, ma.
பார்த்து போயிட்டு வா.
கஷ்டம்தான்.
அவனை
I
வீட்டுக்கு
never said
அவன்
no.
ப்ளீஸ் சம்போ, ஒரு ஹெல்ப்பும்
You
பண்ண
go to
மாட்டான்.
அப்போ அண்ணனை வர சொல்லு.
கஷ்டம்தான்.
Hope everybody enjoyed the video. It was all about how we need to support persons with schizophrenia and how support can walk miles. Now that we've come to the end of the session, I would like to thank each and every one of you for being part of the session. I would like to extend a special thank you to all the speakers for today who gave us such an informative session. I would like to read out the program schedule for tomorrow. We will be having at 10:30 a.m. we will be having a debate. That is, the topic is people with mental illness, to marry or not to marry. And at 12 o'clock, we will be having a panel discussion. Can people with mental illness be employed? The Zoom meeting and the ID link has been provided. I would request each and every one of you to be part of tomorrow's session. It is going to be definitely very interesting. So kindly be there. Till then, thank you. Stay safe. Take care, everybody.
Thank you.